Hello, everyone. My name is Cheema, and I'm a surgical resident at Montefiore Medical Center in the Bronx. Thanks to America's Hernia Society for inviting me to present our work. The title of this talk is Risk Factors for Incisional Hernia Recurrence and Surgical Site Occurrence or Infection in the Abdominal Transplant Population. I have no disclosures. Incisional hernia repair following after abdominal organ transplantation is more common compared to the general population following non-transplant laparotomy, with estimated incidence of 15% after kidney transplants and up to 34% after liver or pancreas transplants. There's a lack of large-scale data analysis on hernia recurrence and surgical site occurrences or infections, and those which require treatment or procedural intervention following abdominal organ transplantation, known as SSO PIs. We aimed to investigate and evaluate risk factors for recurrence and SSOs and Is after incisional hernia repair following abdominal organ transplantation, utilizing the America's Hernia Society Quality Collaborative Database. Data was obtained from the AHSQC database. Inclusion criteria for the analytic cohort were patients aged at least 18, undergoing incisional or ventral hernia repairs, who had previously had a pancreas, kidney, liver, or combined organ transplant, and who had completed a minimum of 30 days follow-up. The primary outcome measures were SSOs and SSIs, as well as SSO PIs at 30 days, and recurrences over 2 years postoperatively. The initial cohort of 58,910 patients in the AHSQC database was narrowed down to 166 patients after filtering for the criteria described here. Baseline characteristics are summarized here. Median age was 59 years, median BMI was 31, and 64% were male. Median hernia width was 12 centimeters, and all were incisional hernias. Of the 166 patients, 66% underwent liver transplants and 34% underwent kidney transplants. 34% had a history of a prior hernia repair, and among these patients, 39% had 2 or more hernia repairs. 17 out of the 166 patients, or 10%, had a history of an abdominal wall SSI prior to the hernia repair. Immunosuppression rate was reported as 81%. 88% were ASA 3 or above. Detailed results can be seen here. 4 patients had intra-op complications. These included bowel and bladder injuries. In terms of 30-day outcomes, 13 patients were readmitted. 17 patients, or 10%, had an SSO or an SSI. These included 2 superficial SSIs, 10 seromas, 4 with cellulitis, and 3 with serous wound drainages. There were no deep or organ space SSIs. Overall complication rate was 26%, and there was 1 mortality. Median length of stay was 4 days. The SSO and SSI rate at 90 days was 19%, or 6 events out of 32. And at 180 days, it was 7%, or 1 event out of 14. The long-term composite recurrence rate was 28% over 2 years of follow-up, or 21 recurrences out of 75. The breakdown of the recurrence rates were as follows: 1 out of 166 at 30 days, 11 out of 47 at 180 days, 11 out of 30 at 1 year, and 2 out of 7 at 2 years. In the univariate analysis as seen in this table, history of diabetes was associated with an SSO or SSI. In addition, so was BMI and a history of open abdomen. Immunosuppression had a negative correlation with SSOs and SSIs as well as with SSO PIs. BMI was also associated with 180-day recurrence with an odds ratio of 4.5. Whereas a history of hypertension remained significant for recurrence at 2 years with an odds ratio of 11. ASA type, hernia width, transplant type, mesh type, operative approach such as minimally invasive or open, and performing subcutaneous flaps and drain placement were not risk factors for future SSOs or Is within 30 days or for recurrence over 2 years. The overall recurrence rate in this study is 28%. The study also points out that obesity, diabetes, and a history of an open abdomen are associated with SSOs and SSIs, while hypertension is associated with recurrence in the abdominal organ transplant population. This is consistent with prior literature that patient selection plays an important role in hernia surgery. Modifying these risk factors should also be an emphasis in the preoperative assessment period. Interestingly, obesity led to higher SSOs and SSIs at 180 days, but not at 2 years. Longer follow-up in this study may be necessary to explain this. This study interestingly found a negative correlation with SSOs and Is and SSO-PIs for those on immunosuppression. The immunosuppression rate was only 81%, despite this being a post-transplant cohort. The reason for patients not being on immunosuppression was not reported in the database. Furthermore, access to individual patient data was not available either. Thus, it's not known if these are kidney or liver patients, as this ultimately determines the choice of the immunosuppressive regimens. Larger cohorts and groups that are more homogeneous will be necessary to confirm these findings. However, this and other more recent studies point out the importance of focusing on specific cohorts and operative approaches. In our study, 63% of patients underwent myofascial release and 14% had subcutaneous flaps raised. Neither of these approaches inferred higher risk for SSOs or Is or for recurrence at 2 years. Despite 97% of the cases being elective, postoperative complications occurred in 26% of the patients, signifying the complexity of such cases in this population. The informed consent should include the potential for such complications and consider preoperative factors such as comorbidities, past abdominal surgical histories, and hernia width. Obesity was noted to cause increased recurrence at 180 days postoperatively, while hypertension caused increased recurrence at 2 years. This result points out the importance of looking at both short and long-term outcomes. Future studies should also take into account patient-reported outcomes and include quality of life metrics to further improve upon hernia repair outcomes in such a challenging, relatively immunosuppressed population. In conclusion, history of an open abdomen, diabetes, and obesity are risk factors for SSOs and SSIs, while obesity and hypertension are associated with short-term and long-term recurrence after incisional hernia repair following abdominal organ transplantation. Immunosuppression had a negative correlation with SSOs and SSIs. This should be interpreted cautiously in view of the small sample size, low follow-up rates, and the inability to access the exact immunosuppressive regimen. Baseline comorbidities seem to be the main drive for hernia outcomes for this transplant population, similar to the general population. Larger cohorts and longer follow-up are necessary to delineate preventable risk factors for SSOs and Is and hernia recurrences after organ transplantation. Here are my references. Thank you very much for your time.